It's never one person or a pair like Count Gibson and myself. It's tens and then hundreds and then thousands of people who are involved in making health centers real.
The practice of caring for an individual or a family within the community started right here in Boston 50 years ago with the establishment of the first community health center. Both Doctors Jack Geiger and Count Gibson, who were from Tufts Medical School, envisioned community-based neighborhood health centers that would treat the entire family rather than just isolated medical problems.
I remember talking with Count Gibson and Jack Geiger just after I arrived in the Senate about this new idea that they had developed out here at Columbia Point in 1964.
They in fact invented the patient-centered medical home 40 years before this concept was adopted nationwide by the medical system at large. Jack Geiger saw community health care as an essential part of the civil rights movement. It began with residents being organized and eventually led to empowering communities in the broadest context of improving overall health.
Hola Gladys, ¿cómo está? Mucho gusto de verla, tiempo de no verla.
They're not more dedicated, more concerned, more passionate, able, more gifted, or talented people than those that work in the neighborhood health centers in their community. These are men and women that take a source of satisfaction about making a difference in people's lives.
Thank you.
Every day, community health workers carry forth the legacy of the movement to better the lives of some of the most vulnerable people in our Commonwealth and across the nation.
This is actually Dr. Rhoda.
Good morning, Dr. Rhoda.
Practice within community health centers can become far more important than just providing primary care visits. Community health centers have state-of-the-art buildings and equipment and information technology and the intangible assets of working with the community to become part of the movement, to engage in the community governance, to look at communities and to assess their needs and then try to meet them. These all go beyond the basic model of delivery of primary care services. This is what the movement's all about.
I don't know what America would be like if we didn't have community health centers.
There were three strands in the origins of all of this. The first was civil rights. I had been in civil rights since my teenage years and the beginning of the Congress of Racial Equality. In World War II, I joined the Merchant Marine because it was the only branch of anything military that wasn't racially segregated in the 1940s. Came back to, in effect, do pre-med at the University of Chicago. It was 1947, discovered that the University of Chicago hospitals had elaborate systems for turning away black patients. And the lying-in hospital flatly refused to have any black maternity patients admitted. Billings and all of the others had written instructions to the admitting clerks as to how to turn away black patients and send them to Providence Hospital by lying that clinic didn't meet today, or somehow your name isn't on the list, you better go to Providence, and ended up running an almost 2.5-year, 3-year campaign. This was all perfectly legal in 1947, you could do it, to crack that and get it changed, and was kind of half-heartedly applying to medical school and discovered, some of my partners in this effort were Howard and Meharry medical schools, discovered that I was being blacklisted by the AMA. They had sent out a letter to all the medical schools calling attention to my extracurricular activities. I don't know if I ever told Tony this story. And not being too swift, they had sent it to Howard and Meharry as well, who instantly called me up and said, "You're in trouble, you're not going to get into medical school, you better come here." It was a couple of years later before I started medical school at Western Reserve, which didn't care what the AMA said. And in the second year, standing on the steps of the medical school in Cleveland, I had a moment of epiphany. You looked out from those steps and you could see the teaching hospital, and beyond that, you could see the city of Cleveland. And it occurred to me, the orientation from civil rights and social justice concerns, it occurred to me that out there in Cleveland, who got sick and who didn't, and what they got sick with and why they got sick, and what happened to them then, and what was the nature of their interactions with the healthcare system, all were not just biological phenomena, they were social phenomena. And I thought I had invented social medicine. And I ran to the library and discovered that Rudolf Virchow and John Simon in England and a bunch of other people had invented it about 150 years ago. And that, more than that, the American literature of the time was pretty deadly in this field. It was all touchy-feely. It was stuff about the whole person and the whole man or the whole woman. It wasn't anything that you did, it was just an attitude that you had. And then a mentor and friend at the Rockefeller Foundation sent me a bunch of reprints about a place in South Africa that had started out when Sidney Kark and his colleagues at the University of Witwatersrand Medical School in Johannesburg were medical students. Evidence that maybe the only true agents of change in medical education are the students themselves, and had gone on as graduates to start a string of something called community health centers. In apartheid South Africa, they were resistors to apartheid. During a narrow window of opportunity when the government, not for the most humanitarian of reasons, had figured out that they had better do something about the health of the African working population that was the economic engine for South Africa's growth and prosperity. And what they were doing from these reprints looked real, and I decided that if it was real anywhere, it was real there, and I ought to go and look at it. It was my first exercise in grantsmanship. I cobbled together 5 months out of all of my vacation and elective time in the senior year, and figured out there were 3 places that had to say yes if I was going to get there. Western Reserve had to say yes, I could go. The University of Natal, with which this health center effort was affiliated, the one medical school that then existed in South Africa for non-whites, they had to say yes, I could come. And the Rockefeller Foundation or somebody had to say yes, they would pay for it. Thank God, this was before satellite phones, faxes, rapid international communication, the internet, or anything like that. It was all snail mail. So I figured the odds were pretty good, and I wrote each of them and said the other 2 had already said yes. So they all wrote back and said, well, in that case, okay. And I got to go, and it changed my life. I learned about community-oriented primary care. In apartheid South Africa, you could not, even if you were blind, escape the relationship between the social order, the distribution of income, people's rights, and the distribution of illness in that society, of health and illness in that society. And it became clear to me that what I wanted to do was fashion a career in international health. And came here to Boston. I wanted an internship in medicine at a teaching hospital that took care of poor people, and did my residencies on the Harvard service at Boston City, which surely filled that category, and kept thinking about going back to Africa. By this time, you'd be relieved to note we're at least up to 1964, and it was the summer, you will remember reading about at least, of Freedom Summer, the voting rights effort, the 1,000 medical students from the North that were going to come down to work together with the indigenous civil rights workers from SNCC and the Southern Leadership Conference in Mississippi, not just on voter registration, but on freedom schools, on education, on community organization and mobilization. That was the spring in which James Chaney, Andy Goodman, and Mickey Schwerner were murdered and buried under a dam. We had in anticipation, we as maybe 20 of us initially from around the country, spontaneously formed an organization called the Medical Committee for Human Rights, MCHR, which ultimately sent hundreds of physicians, social workers, nurses, public health nurses, psychologists, and others to Mississippi that summer to provide what we call medical presence, to take part in all these activities, but to assure the civil rights workers, those from outside as well as those from Mississippi, that we were there if they needed it to provide them with medical care and to join in those efforts, and in the process to document the health status of the black and poor white populations in Mississippi. And I went down as field coordinator for that effort. I had just taken an appointment as an assistant professor at the Harvard School of Public Health, and on the first day on the job, I took a leave of absence for 2 months to go to Mississippi that summer. And in the course of that experience and taking that long look around, realized that I didn't have to go to Asia or Latin America or Africa, that we had it all here. Not at the same absolute level, but at the same relative level, that we had populations that one could rapidly identify that suffered all the burdens of poverty, of dangerous living environments, of inferior education, of unemployment, of housing that was unfit for human habitation, for problems of malnutrition and infectious disease, and lack of resources and lack of access to health care. Blacks in the rural South, Hispanics in the Southwest, people of color in the urban ghettos anywhere around the country, whites in Appalachia, Native Americans on the reservations. There was an identifiable list, and there was no coherent or organized response to that set of problems. This is where Tufts entered. One of the people that I had recruited to come to Mississippi for the MCHR effort that summer was Count Gibson, Dr. Count Gibson, who was then chair of preventive medicine at this medical school. Count came from Georgia. I later learned from Susan Reverby, the great historian of Tuskegee, going through some archives, that when Count was either a senior resident or a junior faculty member in his first year at the University of Virginia, he wrote the first letter that Susan Reverby could ever find protesting the ethics of the Tuskegee syphilis study that you have, I'm sure, all heard about. And Count, not only out of his commitment, which he thought about, but because of his accent, was enormously valuable. The longer he stayed in Mississippi, the deeper his southern accent got. And when we were stopped by the cops, we would shove his head out the window, and he would talk to people, and very often we got away unscathed. Count and I, as part of the Medical Committee for Human Rights after that summer, kept coming back. I had found some rich people in Bethesda to start a little 2-bit public health nurse staff volunteer clinic in a tiny community in Mississippi, Mileston, but it wasn't much of an effort. And in December of '64, there was a meeting in Mississippi that Count and I attended of all of the kind of leftover civil rights workers and Head Start workers struggling with the question of what do we do now? And that day, I don't know why it took so long, I remembered the Rural Health Center in South Africa that I had worked and studied in, and the Urban Health Center that I had worked and studied in, and said what really needs to happen is that some northern medical school ought to come down here and start a comprehensive teaching community health center. And everybody said, what's that? And I kind of explained that model, and everybody kind of ran around the room and said, well, you got to do that. But it was just a pipe dream. We flew out, Count and I, to come back to Boston and got grounded by fog in Atlanta, and Count said, let's talk about the deal. I said, what deal? He said, we don't have any money, but if you can find the money, Tufts will sponsor this. In January, I walked into the other strand that Tony has mentioned. There was a brand new federal agency, the so-called War on Poverty, the Office of Economic Opportunity, the source of something called a community action program, and with a commitment very different from a lot of what the federal government tended to do, to be working with the people in the communities and with people in poverty, what came to be known as maximum feasible participation of the poor and their communities themselves. And I got handed off to their director of research and development, an unsung hero by the name of Sandy Kravitz. And in January, walked in to see him, and I spent about 3 hours with a yellow pad laying out what a community health center was, what its relations to communities were, what its kinds of interventions were, describing those South African models. And at the end, said, what I need is $30,000 for a feasibility study. That's the usual academic two-step. And Sandy Kravitz looked at me and said, you can't have it. And I said, why not? He said, you got to take $300,000 and do it now. Everybody needs to hear something like that once in their life, at least. I didn't have the faintest idea how much it would really cost. Came back to Boston, sat down with Count Gibson, and we realized two things: that we had to make real budgets, but secondly, that if we were going to do something 1,500 miles away in Mississippi, there were two sets of people predictably that were going to scream. One was the white power structure of Mississippi. The other was poor people in Boston who were going to say, we are sitting on your doorstep. What are you doing 1,500 miles away without taking care of us? And we realized we needed to add a Boston Community Health Center. And this school and Count's department had prior relationship with Columbia Point. It was perfect for these purposes. It was an isolated community of public housing then, 8,000 or so people in 1,500 serially numbered apartments, an epidemiologist's dream, cut off from Boston by 2 expressways and a set of railroad tracks. As we were later to learn, the average door to a Boston hospital to back home at Columbia Point, the average time for people in that community was 6 hours. To get there, to wait, to be seen, to get home. No doctors, no immediate access to health care. We had no trouble getting approval for Columbia Point, but they were, and Sergeant Shriver, the then head of OEO, was terrified about getting, number one, getting involved in health, number two, more importantly, getting involved in Mississippi. One of the lessons is it's important to understand the law and the social circumstances. I had sat down and read it. And when OEO was proposed, Southern governors had screamed because they understood that this was a mechanism that would bypass all of their strategies of state control and give grants directly to poor, translate for them, black communities with a degree of autonomy that simply hadn't existed before. And they insisted in the negotiations over the legislation that any governor could veto an OEO planned project in their state. Now, Sergeant Shriver could override that veto, but that wasn't going to happen too often because you couldn't use up that much political capital when the budget for OEO had to go through Congress and get passed to be renewed every year. But the Southern governors had allowed an exception to the veto process, which was for any grant to an institution of higher education, because they were hoping they would get some grants for Ole Miss and the University of Alabama. There's nothing in the law that said OEO couldn't give a grant to an institution of higher education in Massachusetts to do something in Mississippi, we just reinvented carpetbagging. The only person who could veto that grant was the governor of Massachusetts, and he didn't care and wasn't about to, so we were veto-proof. It's really important to understand, if you are going to change the apple cart and innovate and confront established power that stands in the way of equitable access to health care, to know where your opportunities lie and what the social and physical circumstances are. Shriver was still so nervous, and this is, I think, another first. He kept stalling and wouldn't approve the Mississippi site choice and not meeting with us. And finally, one day when I knew he was going to be testifying on the Hill, I took the dean of Tufts Medical School and the vice president of Tufts University, and we flew down to Washington, walked past his secretaries, and staged a sit-in in Shriver's office. I think it is the only time in the 1960s when the dean was sitting in, not the students. And Shriver had to meet with us. He delegated it to the then head of Head Start, Julie Richmond, and we negotiated over the next 4 hours that he would approve our going ahead in Mississippi. We opened the Columbia Point Health Center on December 11th, 1965, 1 year from the time the idea was thought up until the time it was on the ground and actually functioning. Mississippi took longer because we had struggles with the state government, with the state medical society, with others, but we were effectively unstoppable. What happened then, before I come back to a little bit about the lessons learned, what happened then was a rush of other places, other institutions, other physicians and health workers to do the same thing. And 4 more community health centers got grants within the next year and a half or so. Watts in Los Angeles, all of them tied to medical schools or health departments. Watts in Los Angeles tied to UCLA. Martin Luther King in the South Bronx tied to Albert Einstein. Miles Square in the Chicago ghetto tied to Rush Medical School. And Denver tied to the Denver Health Department and the University of Colorado, all as research and demonstration grants, so-called, because there wasn't any other way, any other category to fund it. In the summer of 1966, Ted Kennedy, a relatively new young senator then, came to look at Columbia Point, recognized, I think, realized that this was, and health was already his thing, a model that deserved replication. And we went back to Washington and wrote the legislation that created an Office of Health Affairs to fund community health centers within the war on poverty, and allocated the first $50 million for that purpose. And gradually, over the next several years, a lot of congresspersons figured out that getting a health center for their district would be really a good thing. And almost from the beginning, this had bipartisan support. And I should add that medical students came from all over the country to work at Columbia Point and to work in particular at Mississippi. And I think for many it changed their lives in the same way that my life had been changed in South Africa as a medical student. What did we learn? The first lesson was in Mississippi, and in a different way, as I'll mention, in Columbia Point. The first lesson was that it was ridiculous to take a child who had infectious diarrhea and dehydration because he was drinking water from a drainage ditch. This is Plantation, Mississippi Delta, and on the verge of death. And as happened over and over again, we had to do to rehydrate him if we could, to treat his infection, to hospitalize him, and then to send him back to the same shack in the same community to drink the same water from the drainage ditch the next time. And into the drainage ditch, there flowed all of the excrement from what are called sunshine privies, surface privies, outside of the fact that he was malnourished to boot. And so, in addition to the clinical care, we accumulated a whole team of sanitarians and environmental workers, and we started digging protected wells, building sanitary privies, in the same process training people from the local communities to learn to do that work, training local staff. We produced the first 10 registered black sanitarians in Mississippi history. Building on what had been vegetable gardens in Palela, we suggested vegetable gardens for the Bolivar County, Mississippi population, thinking we'd maybe get 100 families. There was a lot of vacant land that we might be able to use. 1,000 families raised their hands. We realized there was a better way to do it with the help of the Federation for Southern Cooperatives. Organized what became a 600-acre cooperative farm, nutritional sharecropping, in which 1,000 families pooled their labor for shares in the crop and grew vegetables, corn, beans, greens, sweet potatoes, you name it, grew vegetables instead of cotton. It was nutritional sharecropping, and it ended malnutrition for the population that we serve. The most important thing we did, it turns out, over the long run, was start an office of education at the health center. The median educational level for black children or adults in Bolivar County was 5th grade in miserable segregated schools. But there were people around that had somehow made it through high school, and an even smaller number that had made it through college, back working as science teachers or elsewhere, mostly in the education system, a population that had been cut off from any knowledge of how you got into professional training, how you got into professional schools or colleges or prep schools, how you applied, how you found out about scholarships. And we started an office to identify such people, and with the cooperation of institutions around the country, to facilitate scholarships and placements. Another great credit to this institution, this was pre-Bakke, Tufts set up an additional 10 places in its medical school for students from Mississippi and northern inner cities, students of color, with scholarships to produce physicians from these communities, using some of its overhead money from those grants for this purpose. In the first 8 years or so that we were there, this program, including but not limited to Tufts, from that community produced 5 physicians, 7 PhDs in the clinical sciences, about 40 registered nurses, a half a dozen social workers, some pharmacists and dentists. And what happens, it turns out, is when you do that kind of intervention, it is what the cardiologists called antegrade, forward flowing. If you take a woman from a plantation shack and train her, give her the opportunity to become, let's say, an LPN, you vastly increase the probability that her kids are going to college. That's a health intervention, because we know the relationship between educational status and health status, and it is epidemiologically very clear. There are now, we've lost count, but the last time we counted, 150 or so people of color from Bolivar County alone who are now in the health professions at some level, from technician up to physician and clinical scientists. And when I go around the country talking to other health centers and asking what's happened to their local indigenous trained staff, you hear the same things about their children. Health centers are a way of, not just of giving clinical care, a way of intervening in community life, a way of merging clinical care with interventions that address the root causes of illness in the first place, and have one other important characteristic. When the law got rewritten in 1975, it defined federally qualified community health centers as having to be not-for-profit corporations with an elected community representative board of trustees, the people who accepted the grant and had responsibility for it from the local community, and 51% of that board for every community health center. By law, 51% have to be patients of the health center. It is the only part of the American healthcare system where patients and communities have that kind of voice in the policies and practices of and the control of the health services they need and use. Columbia Point was harder. Urban is harder than rural. The pathologies are different, the resources are different, but the basic principles remain the same. There was a great deal of maternal health intervention, a great deal of substance abuse intervention, a great deal of teaching with regard to parenting, a great deal of mental health interventions. There are now more than 1,000 community health centers operating at almost 4,000 sites because many of them have satellite operations, clinical facilities at multiple points. They take care of 15 million people. There is a ton of literature by independent sources documenting that they provide care of superior quality. A study by Barbara Starfield in Florida examined community health centers there in comparison with outpatient departments and with private solo practitioners, and documented that at modest cost, they provided a quality of care that was superior to any of those other providers. And that's been replicated over and over again. Part of it is because they do function as medical homes. They do provide continuity of care over the years. One of the things we need always to keep in mind, not very much emphasized in our medical education, is good studies of attributable risk. Paula Lance, David Williams, and their colleagues then at the University of Michigan have a handful of studies alone on this, looking at all of the usual suspects in personal behavior and lifestyle choices: smoking, drinking, substance abuse, bad diets, lack of exercise. Yes, they are important. They looked at the life expectancy and mortality rates, morbidity and mortality rates between the poor minorities and the mainstream, and calculated that generously those lifestyle choices accounted for maybe 30% of the difference. And other studies looked at the contribution of access to health care to the life expectancy of a population, the health status of a population, and discovered it was startlingly modest, about 12%. That's a tough thing to absorb when you're a medical student. It doesn't mean that what you do patient by patient by patient is unimportant. Quite the contrary. I've got 5 stents in 3 different coronary arteries, and I wouldn't be here if I didn't have that kind of expert individual medical care. But we know that access to quality health care doesn't do it all by itself. We know this from Canada, the UK, France, Germany, those developed countries, all of which have universal access to care. And when you look at their populations, there is the same social class gradient. If you are wealthier, better educated, and up at the top, you're healthier. And in that society with access to health care, if you're down lower on that ladder, you're sicker and you die sooner. And that's particularly true for the marginalized groups that exist in every modern industrialized society. Community health centers are a unique kind of intervention, the possibility of intervention in those social dynamics. And for people interested in a career that involves one of the reasons I would like to think that motivates everybody who goes to medical school, not just because their interest in clinical care, not just because their interest in biological research, those are real, but going to medical school is in part, for almost everyone, I think, part of a desire to make the world a better place. Community health centers, I think, are a tribute to a small group of people, if they are lucky, being able to start a set of institutions that change the society, fill that need. And as you will be hearing, I think, from the community health center people that are going to talk to you next, they offer a way to meet that fundamental need of making the world a better place here in the United States. I know that the people here who've gone to India as part of Tufts, the people from other medical schools or residency programs that have gone overseas, tend to come back with fresh eyes for our own society. That's one of the major benefits of that kind of experience. It's possible now to have that kind of experience still in our own country, and I think to have careers that merge social intervention, public health intervention, clinical primary care, continuity of care, and a kind of relationship with community that is beyond the one by one relationship we all attempt to establish with our patients. Let me close with one story. One of the pitfalls, I think, of, well, two stories, but I'll be quick. One of the pitfalls, I think, of medical education is that we are of necessity trained so specifically to look for pathology. And the society helps us to think of poor communities of any race or ethnicity as sinkholes of pathology. And the data tend to support that in health. What that facilitates overlooking is that there is also an epidemiology of resilience, an epidemiology of strength, an epidemiology of capability in those same communities. Two examples. There was a woman named Elsie Dorsey who grew up the child of sharecroppers, picking cotton in Marigold, Mississippi, married at 16 to another sharecropper, had 6 children, dropped out of school in the 9th grade, unusual in itself to go that far, to become a chief aide to the great civil rights leader Fannie Lou Hamer, then joined our health center as a trainer of nurse aides, did her GED in a program we had at the health center. I forgot to mention that. We did, the staff at night taught college prep programs and a GED program. She got her high school equivalency, became the deputy director and director of the farm co-op, a huge enterprise, did that for several years, and then just skipping college, was admitted to the Graduate School of Social Work at a Northern university, graduated with an MSW with honors, came back to Mississippi, worked as a social worker for the Delta Ministry, the Parchment Prison Project, and others, in order to launch all of those 6 children in college. With that underway and accomplished, she went to Howard University and did a doctorate in social work, and Johns Hopkins, and a certificate in health management, and then came back and took my old job as director of the Delta Health Center, where she had started as a trainer of nurse aides years before. She is from deep poverty and is one of the smartest people I have ever met. There is another woman that exemplifies the same thing and kind of stitches this all together. One of the organizations I helped form and belonged to and led for a while was called CHISA, the Committee for Health in Southern Africa, which was the major American support group for the health sector resistance to apartheid in the 80s, late 80s, in the fiercest part of the struggles in South Africa. And every other year, we used to organize workshops in New York with all of the African National Congress health people in exile, and occasionally people from within the country that could get a visa to come out briefly and network and give papers and talk to Americans. And we would always see to it that after the workshops, they fanned out to all the medical schools, at least in New York, to give seminars and kind of spread the word about the struggle and what they were doing. And a woman came to the City University of New York Medical School, a physician, graduate degrees from the London School of Tropical Hygiene and Medicine, advanced training in pediatrics, very impressive person, and gave her seminar. She was a leader of the ANC health sector in Great Britain. And we were walking across the street afterwards to have lunch, and idly I said, "Tell me, where'd you grow up in Mississippi, in South Africa?" And she said, "Palela." And I said, "How old are you? And how old were you in 1957? Turned out she had been my patient as a skinny 9-year-old girl when I was in Palela, and had a vivid memory of this weird white foreign couple that had been hanging around there. Well, the great epidemiologist John Castle, who had been a clinical director early at Palela before he came to North Carolina, and morphed into a social epidemiologist, had gone back 10 or 15 years later on vacation, really for an anecdotal study, an observational study. All of those health centers had been shut down by Verwoerd and the apartheid government in 1959 or 60. Was there any visible residual effect? And what he found was, Palela district as compared to similar economically situated black districts, there was no residual health effect, but one. That is that there was a higher, strikingly higher level of educational aspiration and educational achievement in the population that had been served by the health center than in other similar populations. Well, it was just observational, so I wasn't sure it was true. Here was somebody that I could ask about it, that came from there, that was now this accomplished physician. And I asked her, did the health center have anything to do with what happened to you and your educational achievements? And she said, obviously, of course. I saw the black nurses, I saw the interracial teams, I saw what it was possible in the society to become, and that inspired me. And then she thought a minute, and she said, well, to have that effect, you had to live in the part of what was then called the tribal reserve. Part of the tribal reserve that was near the health center, so you visited frequently, not just occasionally, and really had a chance to understand what was happening there. And that made sense. And then she thought a little more and said, but in addition to that, I think you had, for this effect, you had to live in the part of the health center that was close to the highway. And that didn't make any sense. And I said, why is that? And she said, because you had to really understand that there was a road out of this place. That's what health centers do. They help to construct a road out of the illness, the concentrations of poverty, the environments that make people sick. The kicker on this story is that her name, this woman's name, was Nkosazana Zuma. She was Nelson Mandela's first health minister of South Africa after liberation, and she is now South Africa's foreign minister. So there are resources in the communities we serve that can enrich our lives. Thank you for all your time and attention this morning.